So, thank you very much. It's always a great pleasure, and I always feel quite honored when I'm asked to come and have an opportunity to discuss and speak about the things that I do on a daily basis, and a lot of that has to do with treating age-related macular degeneration. So it's something I'm very passionate about, something I always enjoy speaking about, and hopefully this afternoon I'll be able to enlighten you with how we used to do things, how we do things now, and look towards how we might do things in the future. It's a very timely discussion because we're going to have a new drug available in Canada very soon, perhaps as early as next month, for the treatment of wet macular degeneration. So I think it's timely that we review how we do it and what led us to treat macular degeneration the way that we do currently. So I'm going to let's see if this works better. Perfect. So for the next 30 minutes or so, and I'll leave time for questions for sure, I'm going to just talk a little bit about the magnitude of the challenge that we deal with when we're addressing macular degeneration, how we fought this disease before we have some of the very modern, successful therapeutic options that we have today. We'll discuss what we're doing now and why, and then we'll look towards the future. So macular degeneration is a big issue. It is in all of the developed world the leading cause of blindness. So on a world scale, we think of other diseases like cataract and glaucoma and trachoma. But here in Canada, when we think of blindness on the largest scale, it's macular degeneration and diabetes, with macular degeneration still the leading cause. It has a huge, of course, social and economic impact when we think about our society and the fact that the average age of our society is increasing and the number of active and robust people in the 70 to 80 plus age group continues to grow at a significant rate, and so we have to address vision loss in that age group. Whenever anybody talks about macular degeneration, they always divide it into two forms. The wet form and the dry form. We heard a little bit about the distinction between those two forms earlier, but I always say that the dry form is primarily loss of pigmented cells in the back of the eye, as well as the accumulation of sort of the byproducts of cellular metabolism that build up over our life. So I make the analogy that dry macular degeneration is a little bit like gray hair. The color is changing at the back of the eye. In most cases, it's fairly benign. Unfortunately, about 10% of people with dry macular degeneration do suffer significant visual loss as a result of the loss of those cellular components of the back of the eye. We often call that geographic atrophy. But 90% of people who are blind because of macular degeneration are blind because of the wet form of macular degeneration. So the wet form involves the appearance of new abnormal blood vessels which grow into the retinal and subretinal space. So you think of the retina of your eye, like the film in the camera, the classic analogy. The light that comes into your eye is focused on what should be a nice, smooth, thin layer at the back of the eye. And when new blood vessels begin to grow underneath it, they distort that film and that film's ability to interpret light signals. And these blood vessels, then they bleed and they leak. And so the back of the eye becomes moist with fluid and blood, and hence the term wet macular degeneration. And much of what I do now on a daily basis is try to treat wet macular degeneration. Historically, when we thought of wet macular degeneration, we tried things like laser therapy and photodynamic therapy. So we used to try to burn away these abnormal blood vessels with different types of lasers. And the type of laser that we used to treat wet macular degeneration depended upon where these abnormal blood vessels were located. So the most important part of the retina is the macula, the very, very center of the retina, where the light is focused in the back of the eye. And this is the part of the retina that gives us, of course, our ability to read, to recognize faces, to see color, things like that. And when the abnormal blood vessels grew right under the very center of that, If we use the laser to treat it, we destroyed those cells as well as destroying the blood vessels underneath them. And so even very early on in studies like the macular photocoagulation study from now several decades ago, it was shown that actually if you did that, if you took a patient who was having new abnormal blood vessels growing under their center of their macula due to wet macular degeneration, and you blew them away with a laser and you destroyed them, but permanently destroyed the macula itself, they actually did better than those that didn't get the laser. They experienced sudden, significant visual loss, but then their vision loss stopped and you halted the disease. Whereas people who didn't get the treatment continued to lose to the point that they were even worse than those people who had received the laser treatment. But it wasn't a good thing. When a patient comes into your office, they can see a little bit, and you tell them, well, we're going to laser away the rest of the center of your vision so we can preserve as much of your vision as we can years from now going forward. It's a very unsatisfying conversation to have with a patient. So laser actually became used primarily for these groups of blood vessels which were not centered directly under the center of the retina, but were more off to the side, and therefore they could be safely lasered and still protect the center of the macula, so you could destroy the blood vessels before they moved right into the center of the vision. If your blood vessels were right under the very center of your macula and you still wanted to try to treat it, they developed a system of what they called cold laser therapy, cool laser, or what we referred to as photodynamic therapy. So you pre-treated the patient with a chemical, a dye that actually would concentrate in these abnormal blood vessels and bind to these blood vessels and would concentrate in the abnormal ones, but wouldn't build up to a significant amount in the normal blood vessels. And then you used a laser to photoactivate that dye, and that would cause those blood vessels to close off and fibrose down. So it allowed you to attack the abnormal blood vessel, but try to preserve the overlying retina and spare the center of vision, the macula. So that process of photodynamic therapy was used for the blood vessels which were centered right under the center of the macula. And so here's an example of a patient that I treated with a choroidal neovascularization, or a wet collection of blood vessels that wasn't quite in the very center of the back of the eye. And we could sit those patients down at a delivery system and fire the laser into the back of the eye and basically annihilate the blood vessels, but yet preserve the most important areas of the back of the eye. So that patient would have what we call a scotoma, but a permanent black spot off to the side, not in the center of the vision, but off to the side, but we would preserve the center of the vision function in that patient. But it had its limitations, and that was the fact that the choroidal neovascular membrane often came back after those treatments, and it tended to grow, the new blood vessels grew in from the edge that was closest to the center of the vision. So with time, the blood vessels used to creep into the center of the vision. So it tended to be more of a transient therapy, although it worked for a period of time. Ultimately, it usually didn't lead to permanent success. We tried even doing some surgery to make this use of laser more applicable, so that we could try using this hot laser even under blood vessels that were in the very center of the back of the eye. So in some patients, what we used to do is actually physically pick up the retina and move it over. And so the blood vessels were growing right under the center of the retina. But if you could pick the retina up and move it over, the blood vessels under it would no longer be under the very center, and then you could safely laser them away. And the actual technique wasn't so much moving the retina, but we'd cause a retinal detachment, and then we'd move the sclera and all the components of the eye. We'd shift them over slightly externally and then put the retina back down so it was repositioned in a different location. So it's sort of schematically drawn out here where you could see before and after, and there's a big fold of the retina afterwards, but we'd pick this retina up, detach it with fluid, and we'd move it over and plunk it back down again. And now the blood vessels were not located in that center important area anymore, and so we could apply some laser and burn them away, and that would allow us to treat these blood vessels away from the center of the vision. But when you did this to patients, if their other eye was working good, then the two eyes were no longer aligned together. So when you shifted the position of the retina in one eye, it no longer lined up with the other eye. And so they suffered this very problematic form of double vision that was sort of a skewed angular double vision, which was very difficult to adapt to. And so it was primarily used for patients who only had one good seeing eye left. But again, moving the retina like this caused significant distortion in their vision. And sadly, as we saw when we treated new blood vessels that were outside of the center of the retina to begin with, the blood vessels tended to grow back and again tended to migrate towards the center of the new center of the eye, the new macula. And so again, it was not a very good solution to wet macular degeneration. So we turn to the photodynamic therapy. That is the cold laser where we try to blast these blood vessels away but preserve the retina that was overlying them. And for a time, it was actually seen as a very good addition to our armamentarium in terms of dealing with wet macular degeneration. But the blood vessels themselves, after you cause them to scar down initially, they tended to open back up again. And so the therapy had to be repeated, and for reasons that had a lot to do with the way things could be billed, they had to be repeated about every 3 months. And every time you applied this laser, even though it was a low power laser and it wasn't supposed to damage the overlying tissues, it tended to damage both the overlying and the underlying tissues. So again, with time, the destructive effects of wet macular degeneration progressed, and again, patients tended to lose vision as we went forward. There was the occasional home run, smashing success where a couple treatments would really scar down the blood vessels and they wouldn't come back. But generally speaking, the blood vessels just progressed, but more slowly than they would have without the therapy. And so we can really summarize by saying that our historical treatments, laser treatment and photodynamic therapy, they tended to reduce the rate of vision loss, but overall, they didn't actually improve a patient's vision. So when people came in to see us and they were complaining that they no longer had the vision necessary to drive, they no longer had the vision they needed to look at their grandchildren, they didn't have the vision that they needed to read their favorite book, and we'd say, okay, we have a treatment for you, and what it'll do is it will slow down the rate at which you'll lose further vision. It wasn't the message that the individuals coming to see us wanted. They wanted to know about something that would actually improve their vision and restore it and allow them to drive again, or to see their grandkids again, or to read books again. And so the modern era has ushered in this whole revolution in our ability to treat wet macular degeneration as well as many other conditions. And that's what we call the anti-VEGF therapy, because this whole modern treatment regime all comes down to shutting down the molecule VEGF, or vascular endothelial growth factor. And it has really taken wet macular degeneration from a disease for which we lacked restorative treatment, and has allowed us to take patients who were having a lot of blood and fluid under their macula and restore it to near normal anatomy, which of course had a profound impact on patients' ability to maintain an independent lifestyle. So when we talk about our new era of treating macular degeneration, we really are talking about this molecule, vascular endothelial growth factor. And that's a molecule which does many things in the body, but primarily what it does is it allows new blood vessels to grow, to survive, to move or migrate, and also to become leaky. So we need it in our body, and without it, we aren't able to develop as a person. A growing baby would die if this molecule was taken away. And if it's taken away from our whole body, we lack the ability to repair ourselves from damage to our heart and to our GI system and other places. So it's an important molecule to have in our body, but when it runs wild inside the eye, it leads to the growth of these new abnormal blood vessels that then lead to wet macular degeneration, proliferative diabetic retinopathy, and a host of other serious eye conditions. And over the years, we've had many ways to target this molecule, to develop medications which would shut off the molecule of VEGF inside the human eye, and many of them have been proposed and tried, and many of them work, but today we're really left with 3 that actually can be used clinically. And they're molecules that are talked about in the media. They're molecules that are constantly debated. There's one molecule, of course, Avastin, which was never designed to be used within the human eye at all, but which is a very low-cost way of treating wet macular degeneration. And then there's Lucentis and Eylea, which are commercially manufactured medications that are very, very expensive, but also very effective at shutting down wet macular degeneration. All of these molecules act in the same way. You have these cells on the lining of your blood vessels that are looking for the molecule VEGF, and when the VEGF molecule binds to them, it starts this process of new abnormal blood vessel formation, which is illustrated here in both diabetes and in wet macular degeneration. And all of our anti-VEGF molecules that currently exist bind to this molecule before it can actually interact with the cell. And by binding to this molecule, that molecule is no longer able to interact with these newly formed blood vessel cells. And as a result, these blood vessels are starved of this molecule. And it turns out that young new blood vessels absolutely need this molecule to survive. So when they don't get it, they start to shrink up, dissolve, and go away. And that's how we actually take them away in patients with wet macular degeneration, so we can restore the anatomy back to its normal form. So these molecules are available. I use them every single day in clinic: Lucentis, Avastin, and Eylea. And there's many, many, many ways of sort of breaking them apart. The main way they differ is, one of the ways they differ is exactly which form of VEGF that they target, and there's some subtle differences between them, with the Eylea molecule, shown as a aflibercept there, being sort of the more broad-acting molecule. They have different sizes and different configurations and different structures. But some of the important differences are how long they last in our body and how long they last in our eye. So the drug Avastin, which is sort of the cheap alternative therapy, was actually the first one of the 3 molecules in existence. And Avastin was designed to fight cancer. So cancers, or tumors that are growing and proliferating in our body, they require new blood vessels. You have to grow new blood vessels in order to continue to grow the tumor. And the tumor requires the constant creation of new blood vessels for the tumor to grow and expand. And so in cancer therapeutics, they learned that if they turned off those new blood vessels, they could turn off the growth of the tumor. So they made a molecule, Avastin, which is sold and which was initially approved to treat a renal cell carcinoma, but now is used to treat many different forms of cancer in our body. And it was effective. And they noticed that some patients who were getting this molecule for cancer therapy, who also had wet macular degeneration, they were getting this molecule to treat their systemic cancer, but their wet macular degeneration was getting better. And so the first usage of the molecule, we actually used the same dose we would give to a cancer patient to treat an eye patient. And those patients did very well. It can be used systemically to treat wet macular degeneration, but it's very dangerous. When you shut off all the VEGF in the body, you leave these patients open to some very serious systemic side effects. And so right away we realized we could treat people, but we were also making them very sick. And so how could we do it better? And that's when just an individual actually working at the time in the south of Florida at the Bascom Palmer Research Institute decided, hey, instead of giving it to them by intravenous, I'm going to give it to patients directly into their eye. So I can give a tiny fraction of the dose and put it only where it needs to be, and thereby I can really reduce the systemic side effects from this medication, but still have it effective within the eye. And that was done, and it turned out that that worked very, very well. But But that molecule, of course, is designed to hang around for a long time in our body, because when you're treating cancer, you want that molecule to continue to work. And we didn't want that in the medication that we put into the eye. If some of it gets out into the body, we didn't want the potential side effects of that hanging around in the body for a long time. So that's why these other molecules were made, Lucentis and Eylea, which are shown as ranibizumab and aflibercept. But those molecules were created for something that was designed to be specifically applicable to the human eye, reduce systemic side effects, and really last longer in the eye than in the rest of the body. And it turns out they're very effective, and they do work well. They're cleared from the systemic circulation more quickly, and they hang around inside the eye longer. And we started using these in clinical practice, and it turned out that all three of them do control wet macular degeneration very effectively. The initial trials that came out with the drug Lucentis prescribed that medication once a month as an eye injection for 2 years. So 24 times in 2 years, you had to come and see your ophthalmologist, and that ophthalmologist had to inject the drug into your eye, which is a rather daunting regime of therapy. And so Eylea, actually, when it was approved, it came out with an every 2-month dosing cycle. So right away, we saw the advantage of using this potentially longer-acting medicine over our current existing therapy, Lucentis. These trials showed overwhelming benefit, and this shows how much tremendous vision patients increased during some of the initial work, and really rapidly, almost overnight, this became our hallmark therapy for treating wet macular degeneration. But it's difficult to keep bringing patients back to clinic, back to clinic, back to clinic on a monthly basis to stick a needle into their eye. And there's many things that limit our ability to do that. There's physician factors, there's family factors or patient factors, and there's also society factors. The society as a whole issue is primarily the cost of these medications. So they're over $1,000 per injection, and so it's easy to do the math to see how much a course of therapy would cost for one patient over 2 years. There's physician factors in that there's a limited number of qualified individuals that do the injection, although injecting into the human eye is not nearly as daunting a task as it seems. We had Bring Your Kid to Work Day the other day, and I've done it now both for my oldest son and my oldest daughter, and the first few times they watched me stick a needle into a patient's eye, they thought it was really incredible. But after I did it 80 times the first day they came to me in clinic, my son was very frank, and he said, "You know, Dad, I wouldn't say your job is boring, but oh boy, it sure is repetitive." And so we keep sticking these needles into patients' eyes all day, and it helps, it works, we love to do it, but it is a bit tiring. There's also the need to manage other conditions. So people like myself who do these injections tend to be surgeons as well, and have to take patients to the operating room to manage detached retinas and other conditions like that. And there's the fact that I have to be away to do things like perhaps give a talk like this or travel for a conference and things like that. And then patients aren't able to get their injections, and we sort of have to delay them, and it gets a bit long between the injections, and the blood vessels come back and their vision starts to go down. But really, it's patient factors that I think is the biggest thing that limits our ability to apply this treatment today. Every time we stick a needle into a human eye, even though it's technically not an overly difficult thing to do, you can drag bacteria into the eye as well. And so we have to be mindful of a potential infection inside the human eye, which is primarily an avascular space, so there's no infection-fighting cells in there. And so when that happens, the infection can take off quite serious, quite quickly, and it requires more injections of antibiotics to treat it. Constantly injecting a molecule of volume into the human eye does increase the pressure in the eye, and we know that sustained elevations in intraocular pressure damage the optic nerve. That's what we call a glaucoma. And if you don't do it right, and the needle tip hits something it shouldn't, or the patient moves as you're sticking it into the eye, you can hit the lens and you can damage the lens. That's what we call a cataract. Or you can tear through the retina, and those retinal tears will go on to cause retinal detachments. There's a big issue in Canada, and that's getting people to the clinic some months of the year. So we're known to have snowstorms in February, January, even March, December, and patients have to come a long way in some cases to receive these injections. So it's routine that I have patients from Sudbury, from North Bay, from Petawawa, from Pembroke, from Cornwall, from all over the area that have to come and drive to me. So on bad weather days, they can't come in and get their injections, and so I might miss 80 people on a day, and then you've got to fit those 80 people in the clinic later in the month, and that can be difficult. I've had patients get in car accidents driving up from Pembroke, for example, just trying to get to see me to get their eye injections. And then we have a group of people who go south for the winter, and that's a very important thing for them. And so when they're not in Canada, if they have to pay out of pocket in the States, it gets very, very expensive, and we have to try to tailor their injection frequency around that. Patients get sick. So patients break their hips, patients have heart attacks, patients are now in the hospital. They can't come to my clinic for me to inject them. They're often in a peripheral hospital, so there's nobody there who can do the injections. People start to miss their injections, and then the blood vessels come back, and their vision goes down, and they lose their vision. And a huge factor is also the family. So typically my patients, they're getting a needle in the eye. They might normally be able to drive, but on the day that I'm sticking a needle in both of their eyes, for example, they certainly shouldn't be driving. So they require a family member or friend to bring them, and the family member is often in that sandwich generation where the son or daughter is trying to care for their own family and their younger children, is trying to get to work, is trying to run their busy household, and then take the time off to take the family member in to have the injection, which usually they do with tremendous joy, and they love it. But often I see it's the patient themselves that feels that I'm putting this huge burden onto my children in order to get into clinic to see you. And so as a result, they don't want to come in as often to get their injections. So what we really do in practice is we don't inject the patient with Lucentis every month for 2 years, and we don't inject the patient with Eylea even every 2 months for the next 2 years. We try to space it out. And spacing it out is actually based on very good evidence. And trials initially showed us that if you injected them less than monthly, on average, patients did worse. But there's a group of patients who are able to get these medicines injected every 3 months and do very, very, very well. And so we noted that the response is actually quite individual to the patient. And so we don't, as a whole, just tell people I'm going to inject you every 2 months for the next 2 years and you every month for the next year, but we see what the patient actually requires. So we start off typically by injecting the patient 3 times over the first 3 months, or every 6 weeks over the first 3 to 4 months, and then we start to space it out, and we go to 5 weeks or 7 weeks or 8 weeks or 9 weeks, and we inject and we make sure that their eye is dry with no blood and no fluid, and we extend it a little bit more until we find the treatment interval that's specific to that individual patient. So it tries to allow us to individualize to each patient exactly how often they need their medications. And these next slides talk about that, which I just described. I won't bother showing it graphically. It's just the way that we extend things out in order to try to minimize the burden on the patient and on their family, but still maximize the treatment benefits. But clearly, there has to be a better way of doing things than injecting these medicines into the patient's eye so often. And so we're looking for other ways to do that as we look towards the future. And one solution that's been proposed is trying to replace the retina. So when the human retina doesn't function because of these new abnormal blood vessels that are growing underneath it, why don't we give them a new artificial membrane that's sensitive to light? And these so-called bionic eyes or artificial retinas have been in use now for several years. There's many patients with these arrays, these light-sensing arrays that have been surgically implanted into the back of the eye, and these then send their signals to the brain. But when you actually see what practically the patient experiences in terms of vision, it is quite rudimentary and quite limited in that they sometimes have the ability to detect global shapes where a door might be or where a bridge might be, and perhaps navigate a bit. But it doesn't give patients the type of vision that they're really looking for with an artificial or bionic eye, that is, the ability to read or recognize faces and letters and things like that. So although it's a potential excellent solution, it's still very much in a rudimentary state. Stem cells, of course, have been discussed for many, many years. So let's give to the eye these new baby multi-potential cells that can go into the eye and grow and diversify and become any form of cell that the eye needs. And then we can replace that damaged non-functional retina with these new youthful cells that then produce a healthy retina again. And there's been evidence and examples where stem cells can be grown and cultured, and even inside living eyes can grow and culture. The problem is the new cells that develop and grow in the back of the eye, they lack the connections to the brain to send their signals to be processed so that individuals understand what they're seeing with these new cells. So we think stem cell therapy is still a ways off. Gene therapy is a very exciting, revolutionary way to deliver sight back to patients who've lost it. And we heard about this earlier with Luxturna. We've heard about the fact now that we can treat the first congenital eye disease by using a viral vector to place the required gene back into the human eye, which then allows the cells to make the proteins they need and become functional again. The problem is with macular degeneration, that disease really is based on so many different genes that we know of. It's difficult to try to target, discern which ones are the most relevant ones to target and design for that. And so it's still, again, a ways off. What might be coming much more quickly, though, is being able to introduce a gene into the human eye that has our eye produce the anti-VEGF medication that it needs. So instead of taking the patient to clinic and injecting them every month or every 2 months with one of these medications, we give them a 1 or 2 time injection, and we give the eye the machinery it needs to produce its own anti-VEGF medication going forward. Other examples that attempt to reduce the burden of treatment include these forms of depots, which are sewn into the human eye, and then we take the drug and we fill up a little container within your eye of the medication that is then slowly released. And there's one that's now in clinical use in the United States that will slowly release Lucentis over 6 months. So it takes the burden of treatment down to an initial implantation and then maybe 1 to 2 top-ups per year. But there is significant risk associated with sewing one of these into the eye, especially the risk of vitreous hemorrhage and detachment. So what we've really been looking for is maybe perhaps a medication that lasts a lot longer. And that's what I alluded to at the very, very start of my talk, that we do have such a medication now approved in the United States. So it's called brolucizumab, or BioView. They're going to call it BioView when it becomes available here in Canada. And it is not a leap forward, it's another step forward. And so it's a medication that's designed to be used every 3 months to treat wet macular degeneration. So if you think of the original approved medication every month, now to a medication that lasts every 3 months, we do have something that potentially could suppress VEGF production for a longer period of time. And the clinical trials were done around the world for this medication, but Canada and here at the University of Ottawa and myself were participants in the study, and we definitely noticed that these patients could do quite well by being injected every 3 months compared to the patient receiving Eylea every 2 months. And their retinas turned out to actually be a little bit drier, and their visual acuity was exactly the same. So it's a new medication. It's just been approved in the States. It's about to be approved here in Canada, and it's about to come into our clinical practice. And the good thing about this medication, as for all of our medications, is once that it's available to us, we'll find out exactly how it applies to each individual patient. And patients that perhaps were stable at every 2 to 3 months on the existing medications might be able to go to 4 to 6 months with this new medication. So it really does, I believe, offer the potential to extend the treatment burden on our patients and offer the potential to reduce the burden on the family and the healthcare system, because it's actually going to be a cheaper medication than those that are currently in existence. So to summarize what I've spoken about over the last 30 minutes or so, macular degeneration, it remains the leading cause of blindness in Canada today. Its destructive form, the wet macular degeneration, is managed by repetitive injections of medications into the human eye. This is a very difficult and burdensome form of therapy for both the patient, for the patient's family, for the physician, and it's costly to society as a whole. But newer treatments are being developed, one of which will come to the forefront very soon here in Canada, that we're trying to reduce that burden of treatment. Thank you.
So we have time for a couple of questions. We have a couple of our staff have the mic, so if you just put your hand up, one of us will bring a mic over to you.
Thanks. Do you have any idea as to why these conditions arise in the first place? I have a theory that one of our problems is eating food that's been treated with chemicals, and that gets into your system, and that does all kinds of things that are not going to be helpful. But if, for example, there are 3 strong substances that are fantastic for dealing with things. I've got a precancerous condition here that's being controlled by, first of all, garlic. That didn't go very well with the wife. And now with ginger. And I think they're known widely. But we really ought to learn to what's causing this stuff as an initial thing, and be able to go to a diet, essentially, which will be much safer. I'm 82 now, and I haven't had anything so far pretty well.
So the risk factors have been delineated. So the risk factors for macular degeneration: family history, race, smoking, somebody said it earlier, obesity, and diet plays a role. And so the conditions, our understanding is that the initial breakdown of the blood-ocular barrier that allows those blood vessels to grow in happens due to the buildup of the waste products of cellular metabolism over our lifetime. Certain races are more at risk for that than others, and clearly if it's in your family, you're at a slightly higher risk. But you can certainly do things to reduce your risk. Number one, don't smoke. Don't start now. And do all the things that your grandmother told you when you were young to keep yourself young and healthy. It applies to the eyes. So people who are more physically active, people who have a low-fat diet, people that have better control of their blood pressure, the risk of developing these conditions is absolutely lower in those patients. The role of diet has been elucidated in terms of we can give patients supplements, and we know that people who take certain antioxidant supplements do have a slower rate of progression than those that don't. And there have also been studies that come out that compares people's dietary intakes. Okay, so the fresh fruits and vegetables that contain lutein and zeaxanthin and beta-carotene, that contain zinc, that contain copper. Patients whose diet is more full of those things compared to people who have less of those things absolutely have a lower incidence of the disease. But some of those studies, it's a bit difficult to know for sure. That's why we can't absolutely say, eat more green leafy vegetables, you won't get AMD, because is it a surrogate measure for something else? So do people who eat those kind of things exercise more and smoke less and drink less alcohol, and they're less couch potatoes than people who have the higher fat diet? So is the diet a surrogate measure for some other component of your lifestyle? But certainly when we supplement people with the things that you allude to, they have lower rates of progression. And in larger studies of bigger groups of people, people with the healthier consumption have lower rate of onset to begin with.
I guess the other thing is, it's amazing how
just what we need in Canada, survive in the winter. Okay, what do I got here?
Question is correlation between the age and the efficacy of these treatments. A person in 50 plus versus a person 90 plus.
Yeah.
How these injections act on.
Excellent question. So people with macular degeneration as a rule are over the age of 55. If they're less than the age of 55, we look for some other cause. There's other causes of choroidal neovascular membranes, for example, myopic CNVM, ocular histoplasmosis, so a condition that's actually quite common in the Ottawa Valley. You can get idiopathic ones. You can get ones post-trauma. You can get choroidal neovascular membranes that form from a variety of other causes. And those patients tend to be younger and tend to have a more beneficial effect from the injections. So if I have a younger patient who has one of the other secondary causes of choroidal neovascular membrane compared to my older patients, they require fewer injections to be completely suppressed, and they tend to be able to spread those patients out longer. We think that's because the other cells around them, so the other components of the retinal pigment epithelium is overall healthier. So it can absorb that fluid more quickly. It can sort of replace the breaks in the blood ocular barrier that allowed for these blood vessels to come in the first place. And then you look at patients. So age is an interesting thing, but you take people who are 80 years old, and there's some that walk in, you swear they're 60, and there's some that walk in and you think they're 110. So I really think at a certain point it really becomes how people have really taken care of themselves and how good their body's systems are functioning over well. And my sicker patients, for sure, they tend to be much more difficult to suppress the choroidal neovascular membrane than in patients who are more juvenile, who walk into my clinic and sit down themselves, compared to somebody who really is immobile, has to be moved out of a wheelchair, clearly isn't eating well. Those kinds of patients don't do as well. So yes, generally speaking, the younger patients do well, but at a certain point, it really represents how the body is doing overall and an ability to recover.
Thanks. The transition from dry macular degeneration to wet, is it a sudden transition, or does it go over time? And sort of the B part of my question is, does the timeliness of the actual treatment predict the efficacy of the treatment itself?
Yeah, excellent. So we call them wet and dry, but of course, nothing in life is wet and dry. There's always a gray area. And so the transition, there are forms of macular degeneration. For example, pigment epithelial detachments. We have choroidal neovascular membranes that don't leak. So we have this transition that's not, when we look at a patient in clinic and we do the imaging test, we do a fluorescein angiogram, look for abnormal blood vessels. Yeah, there's some abnormal blood vessels here, but they're not leaking yet, so they're really a pathological choroidal neovascular membrane, or maybe some of these early new blood vessels may help the retina. They're there for a reason, so maybe they are bringing better oxygen supply. And so there's a transition, a tipping point, and that tipping point is when they start to get exudations, when you get the fluid and blood in your retina. And typically that is quite a sudden transition for most people, and so the bleeding and hemorrhaging do sort of break through quite rapidly. The problem is when it happens in one eye, it's often not noticed because the other eye compensates fairly well. So people will say, I lost my vision yesterday at 2 o'clock in the afternoon. What were you doing? I decided that I would put some makeup on this eye, and when I closed it, I suddenly realized I suddenly became blind in the right eye at 2 p.m. yesterday. But if you look in, the membrane's been there for much longer. It's just that with both eyes open, they didn't appreciate it and notice it. So they often present a little bit later, especially in the first eye. They may not know this transition. Probably the biggest clinical symptom is distortion, so your vision becoming distorted and wavy before you actually get a full-blown hemorrhage. So the Amsler grid is relevant, but it's not like the most important thing. If you're in a room like this, which has straight lines, door frames, windows, and you look at them with one eye and you look at them with the other eye, you'll detect that distortion without having to rely on a specific grid. The important thing, though, is to test the eyes independently, because if you have early changes in one eye, you're not going to appreciate it. The second part of your question was the duration of symptoms prior to the initiation of therapy and whether that influences prognosis. So Absolutely. So if we catch it earlier, there's less of the damaging effect. The natural history of a choroidal neovascular membrane is actually to eventually treat itself and turn into a fibrotic scar, which we call a disciform scar. So they're all evolving towards that scar tissue. And every membrane that I treat results in some scar tissue. The amount that will ultimately be there in the end is definitely dependent on how early we can initiate therapy.